Yeah.
Quite hectic for you, isn't it? We were all taking it easy, but you are doing 10 and 12 seminars a day, which is a lot of work.
Yes, sir. So I'm looking forward to a break.
Oh, well. I mean, for you, it is quite a good thing that happened, isn't it?
Yes, sir.
Remaining 7, 8 days, I want to do some something else. I want to establish some automatic alerts from the National Library in
Uh-huh.
India. So I'll try and do that on my own. But if I don't succeed, then I'll come back to you.
Sure, sir. No problem. Anytime.
Few things I want to set it up. One is one of the books on radiology that I've written about now 11 years. So that needs an edition. But before finding the edition, to have some material, then I can approach the publishers.
Right.
11 years. Did you display this on your circulars, this one or not?
We,
Not really.
no, let me show you which one we did.
Good morning, sir.
Hello, how are you?
I'm fine, sir.
You are late. Some issue with the internet
Yes, sir, I understand.
that restored. That would be good.
Hello, Ashok bhai.
Hello. Hi, Alok. How are you doing?
Yeah, fine, doing well, doing well. Hello.
Ashok, in between, I am going to pay tribute to Ellen Vora. So
Yes,
that
sir.
should be all right.
That should be all right.
It's not in the beginning, but halfway through. Because in the beginning, there are not many people listening. So
Yeah.
Yeah.
halfway.
Good afternoon, sir. Good afternoon.
Good afternoon, everybody.
So, Chandak sir, can we start because we already streaming?
Late by half an hour.
Yeah. Sir, please, you can start. You gave an initial briefing, Ashok?
No, sir. I think you can start with
Okay, let's start. Friends, good afternoon. And this is again Tuesday. Tuesdays with Dr. Thakur sir is back on air. Sorry, initially we had some glitches on internet issues, but now we are hooked up. And many times you must have seen in many meetings, whenever an X-ray is posted, the faculties would ask, do we have another X-ray? What actually they mean is a X-ray taken properly. So let us see how proper X-rays and various positions can be obtained. Let us hear from none other than Dr. Anand Thakur sir. We are all eager to learn, imbibe, and possibly takes a lot of snaps also. So we are ready for you, sir. Thakur sir, can we start with your lecture? Most welcome, sir.
Thank you. Thank you. I'm happy to come back after a break of 2 weeks that rejuvenated me. And I am sure you also got over the boredom that was setting in. Anyway, this is about X-ray. X-ray and orthopedic surgeons are absolutely two sides of the coin. They can't exist without each other. So if we take X-ray, then we must know how to position it. It is, after all, a matter of controlling the shadows. Anybody who has done photography with flash knows how difficult it is to control the shadow of the flash. It can make or break a photograph. Similarly, positioning the patient, and then taking the X-ray is the gist of everything that we do under exercise. In all examinations of the any joint, we need X-rays at 90 degrees to each other. Two X-rays are essential, and they should be at 90 degrees to each other so that you get the complete view, orthogonal view. Now, in shoulder is such a joint that it's difficult to go around. And starting with the AP picture, usual tendency is to make the patient stand and then take an X-ray, forgetting that the X-ray, the shoulder is not parallel to the uh, plate, but it is at an angle. As a result, what we see is that there is an overlap. The glenoid shadow and the humeral head shadow overlaps. So this is not a true AP picture. This is an oblique picture. What we say as a AP picture is really an oblique picture of the shoulder joint, because the shoulder joint itself is at an angle, and that angle happens to be about 35 to 45 degrees. So what is the true anterior-posterior view of the shoulder? For that, we have to tilt either the patient or the film or the X-ray machine so that we get at the line of angle of the
Same to same पुस्तक.
the true anterior-posterior view of the shoulder,
इथे करायचं का?
also mentioned as Greshy's projection. Greshy was the one who instituted this, and it is also goes by his eponym, Greshy. What we do is to keep the patient at an angle of 35 to 45 degrees. This is the film, and this is the axis of the patient. So with the result, when the beam comes in straight, you get that joint. And the beam is also tilted 30 degrees, not 100. It's 30 degrees tilt and 35 to 45 degrees at an angle. That works best. The conventional AP, as we all know, we keep the patient parallel to the plate. So the joint is at an angle to the plate. Here we are. The conventional, the red arrow will show us overlap, while the green arrow, which is the true AP, will show us two joint surfaces separately and parallel to each other. So whatever we did is judging roughly 35 to 45 degrees. Now, if we want to be absolutely correct, precise, every time we repeat it, there is another method. This method depends on the body structures. The tip of the coracoid process can easily be palpated, and the posterior edge of the acromion can also be easily palpated. So one draws a line uh, between these 2 points, and that is we call it as axis. Then we shift the patient in such a way that this axis is right angle to the plate. X-ray film. You can see a marker here. It is right angle we are already given, and the patient is like this. So we make it at right angle to the plate, and then we take an X-ray. That will be the perfect lateral. In the bottom row, you can see the red arrow shows an X-ray which is done by tilting the patient to 35 to 40 degrees, while the picture D shows one which is done with the marking the fulcrum line, that is connecting the anterior coracoid process and posteriorly the tip of the acromion. We connect that line and bring that line at right angles to the plate, then we get a perfect X-ray. So perfection is what we need. So there we are, an enlarged portion. You can see clearly here there is still a little degree of overlap because it's a judgmental. We just turn and twist. Here we are precise, accurate, and that's why we get the best result. We achieve excellence through pursuit of perfection. It's not unusual that this paper came from Germany. German people are known to go for perfection, and they found out a method how it can be done. Now, when you take a true AP, it is easy to diagnose when there is an overlap of the two articular surface. You can. This is the normal one. This is a dislocated one. This is the anterior dislocation of the shoulder. This is pseudo dislocation because there is a fracture here, and that is called hemarthrosis. So it has caused downward displacement because of the hemarthrosis and giving us a picture of a pseudo dislocation, which can also be seen in this way. This is only indicative that there is some fluid inside which is pushing the joint down. Posterior dislocation of shoulder is one which is often missed and is common in 50 years and old. And the true dislocation, a true APV is very useful. We'll see a little later how it is done. Another way taking a lateral picture of the shoulder joint is to take an axial view. You make the patient lie down and beam it through the axilla and you get a perfect picture. This is fine if the patient has a full painless abduction. This X-ray can be taken very easily. However, in fracture or in other conditions where patient cannot abduct, it is very difficult. It's difficult for the patient to lie down on X-ray couch, difficult to abduct, hence axillary view is a painful. Certainly in fracture it is extremely painful. But there is another way of taking a perfect lateral. There is no need to lie on the table, no need to abduct the shoulder. And the view we call it as a Y lateral. Now, how to get that Y lateral is to place the patient along the long axis of the scapula. Then we get the perfect lateral. Here we are. This we have marked out the spine of the scapula, and this is the vertebral border. These two, and now we have positioned this dotted line at right angles to the shoulder, to the X-ray film, and then take an X-ray with a caudal 10 degrees, and we'll get a perfect lateral. We get something like this, and one need to see where is what. So if we trace the lines, then we have something like this, which is the coracoid process anteriorly. And then we continue tracing that line, and then we have the acromion. So we have something there. After that, we try and locate where is the glenoid. Here it is. And then the body. So once you know what silhouette to follow, it is so easy to find out where is what. Once you locate the point to scapula, head of the human, it also resembles a Y. As you can see, this thing very much resembles this Y. And now you can imagine why it is called Y. And one can now trace the head of the humerus, which is lying posteriorly. It is not articulating in the surface. Once you have taken a lateral picture with the Y lateral, you can locate the head of the humerus. It's posterior, it is dislocated one. It's Y lateral. In this picture, it is perfectly looking like a Y. So there we are. This is the way to take it 10 degrees and the marker of the scapular joint, and you can do that. This is a Y lateral which is showing a dislocated shoulder, and this is the picture which was taken after reduction, and now you can see it is in position. This is the Y, and the head is anteriorly lying like this, while after reduction, this is the Y, and the head is right in the center of that Y. So without much trouble to the patient, we can judge and get position. There is no need for CT or MRI in such cases. I'm sharing a true story. A woman in late 50s was riding a scooter. She was pillion and she fell down. She had some discomfort in the shoulder and was unable to use the arm. Luckily, she fell down in front of a large hospital in western suburbs of Bombay. So immediately she went to the casualty. Casualty officer asked for an X-ray, which looks something like this. I said, "It's fine, nothing. You give a sling and then go home." She was asked to come to the fracture clinic, and there probably some junior doctors saw and same X-ray, but slightly better position. And they said, "Okay, nothing. Go for physiotherapy. Come back after 2 weeks, 2 months. You will be fine." After 2 months, I think the consultant saw her and then realized that this has not helped. So he asked for a bilateral, and thing was extremely clear that the head is dislocated posteriorly. He also ordered a CT scan, which told whatever is what. The head of the humerus is posteriorly dislocated and is hooked to the rim of the glenoid, and without this being disengaged, it cannot be reduced closed methods. So a simple X-ray like this would have told the all concerned treatment people that this requires something special, something open reduction, or certainly ask for a CT scan on the first day and then get on with it. Reconstructed motion shows that the whole of the glenoid is in front, head is sticking behind. So this is the importance of this bilateral, is how to take it and how to interpret it. It's an efficient and economical method you can do in your own clinic with 15 mm machine and save a lot of expense to the patient. They are, of course, ultimate measures, expensive. It's not everybody has a CT and MRI in his own clinic. Not yet, at least. Eventually, it will be, but not yet. So, how it works? There we are. Oh, she had open reduction physiotherapy and she worked very well. Now, another view is very useful. It's called scapular outlet view. It is something like the bilateral, but the angles are different, and they show the acromioclavicle joint in different varieties. Now we will just see how they are done. There are three types of acromioclavicular joints. The type 1 is almost flat and is present in about 15% of people. You can trace the line like this and it works quite well. The majority have a slightly sloped one, and that can be traced up like this. This is what we commonly see, a flattish surface. This is a flattish surface right here, and this majority of people will have it. Some people naturally have got a hook there. You can see it doesn't go straight, it comes down. So these people are prone to get irritation of the supraspinatus and cause trouble. Fortunately, the number is very low. This is because of anatomical reason. But we need to know. The scapular outlet view is most useful for this kind of work. Um, you can see that there are degenerative changes as pointed out there. You can see a large acromial spur which could cause symptoms and degeneration also. Calcification of the coracoacromial joint could also cause significant trouble and can be easily seen in a special view. No need for an extraordinary X-ray. This outlet view. Supraspinatus outlet view is cheap, it's simple, easily available, reproducible. All you got to know is how to position it and how to read it. MRI, CTs are good, but they are costly and they can be taken as second line of defense. Axillary view we already seen, and as I said, is alternate method. That one is very painful. Patient, even his worst hit, he can still abduct a little when supported on the side. You can and then keep the X-ray machine in this gap, keep the cassette on the top, and this way one can get the lateral also without causing much discomfort. But while lateral is much better, this is the next part. If the patient is lying down on the table, then it's difficult for him to keep it like that. So to give a saline stand to hold his arm gives a lot of relief, and then patient will allow you a good X-ray. So this is a clinical trick to give a saline stand for a support, and that works very well in favor of the patient. There we are. The saline stand is marked again. when the arm is stabbed to the chest wall and we don't want to move it for some reason or another, our patient resents it, then without disturbing, you can take Lawrence view, which is transthoracic. The sound hand is lifted up and this is shot straight away through the chest wall, and we get a picture something like this. In this position, AP is very easy, but transthoracic or something like this, that will save the day for us. When there is a plating, one can see all the possibilities there. This plain X-ray is very useful if you are going to do a plating. There is a calculation. This is osteoporotic bone, and at 5 centimeters from here, the distance between these two uh, points, 1 and 2 and 3 and 4, is measured, and the thickness is calculated. If the average thickness at these 4 points is 4.3 a normal person, and this is a porotic person, you can see it is much less. If the thickness is less, unlikely your plate will work. Certainly, your standard plate will not work. With locking plate, there is a better chance of its working. But one should be aware then, and then resort to all screws on bicortical mode. If one goes with a very osteoporotic bone, unicortical, there could be a trouble. So this is a method of assessing the quality of bone in a porotic shoulder. This is quite well known that we have this medial hinge. If there is a hinge here, something like this, then the blood supply continues. And if there is no hinge, something like this, then it will lead to a poor blood supply. I'm showing you another example in which lady came up with this X-ray and she had a prompt surgery. Surgery went on very well, and when was which was held very securely. There was no problem whatsoever, and by end of second month, she was getting extremely good results. She was very happy, and her happiness lasted for almost 7 or 8 months. Then she started getting some kind of discomfort.
I didn't catch that. Could you try again?
So when that happened, we took an X-ray, nothing much, but
I
a
didn't
month
catch
later,
that.
uh, there was issue. The head started collapsing. The head started collapsing, and in a couple of months, there was total collapse, causing a lot of symptoms, and required removal of the implant. There we are. So why this happened? If we revisit the first X-ray, one can see that there is no metaphyseal extension. It is blood here, and fair amount of displacement is there. More than 5 millimeters of displacement. Both are prognostic signs, and one could have been able to warn the patient that this is a likelihood of happening. Whether one would go for a primary replacement or hemi, that is discussable. But one could at least tell the patient that this is a clear possibility. This picture is quite famous. Now, acromioclavicular joint and distal clavicle. Just we take a plain X-ray, it doesn't happen. It doesn't give any traction to the joint. So if there is an instability, we will not know. So trick is to give a heavy sandbags in both hands like this. These are 5 kilo sandbags, and patient is asked to lift them. With that, there is an automatic pull on the shoulder, and one can see the displacements if there are any. Like here, there's a heavy weight being pulling it down, and one can easily see the subluxation or dislocation of the shoulder, acromioclavicular joint, which can of course be fixed in this way, and now there are other ways also of doing it. Image intensifier, of course, we all know how to use image intensifier. These are the two most common positions. Surgeon stands on this. The image intensifier is opposite the surgeon, or it could also be at the head end, and by rotating it this way and that way, or by these two positions, one can visualize shoulder in 90 degrees of each other, which is the easy way. Sometimes we resort to clavicular wiring, but there it requires a special type of positioning. Displaced clavicles need fixation because many times this skin is threatened by this spike, and if we allow it or treat it conservative, there is ugly deformity, there is a shortening, and shortening gives a reduced strength in that joint. If it is bilateral, it could be really bad. So for that, we take AP X-rays in two planes, caudal tilt and cephalic tilt. That gives us a clear idea what is happening. On digital X-ray, it is easy to find out the displacement directly. One can measure it, comes to that. I said it's more than 2 centimeters, one should offer surgery to the patient. This patient had more and he was willing for surgery. So we did that. I resort to this titanic elastic nails. C-arm on the fracture side. C-arm is free to rotate 90 degrees. Anesthetist also stays on the fracture side. Surgeon works from the opposite side uh, because the entry is from the medial end of the clavicle. Here we are. This is the fracture side. Anesthetist and the technician. One can view this way and that way, so you can see that how the two views are possible. The fracture line is marked, and then the entry can be achieved through the other side. There we are. The entry is from the medial side of the clavicle. A small drill hole is made, and the wires are passed. You can see the wire progressing across the fracture site. And all this can be recorded by just turning at every step we do this, turn the image intensifier this way and that way as I showed to you. And as the fracture stabilized there. This is day 2. Patient has absolutely no pain whatsoever. So that is a great advantage of this operation. You cannot let him drive his motorcycle the next day, but suddenly his pain is gone. We still protect him in a sling for almost 4 weeks so that the healing takes place. He's a young patient, but very recently, just before the breakdown, I did a patient who had marked displacement. Skin was very, very thin, and this portion was threatening to just come out of that. And his age was 95. It took a while for me to convince the family that this is required, but then they fortunately agreed. We were able to do it in the shortest possible time with minimum trauma. This is the amount of ecchymosis that he had. At 95, everything is so brittle. He had just a fall in the house, nothing great. But this is what happened. He also had a rib fracture. So two together was causing a lot of discomfort. The moment we fixed the clavicle, the rib also got stabilized, and he was very, very comfortable with that. So nailing of clavicle with elastic titanium nail is a very good procedure. We need image intensifier. We need to know how to position your machines, and then a successful result can be taken up. So on shoulder, if you have questions, we'll take up now.
Alok, do we have any question? While discussing with Dr. Jilpilwar from Pusad in the morning, he wanted to know something, how to take a good view of acromioclavicular joint. He commonly does K-wire fixation. So he faces difficulty in that. That is what he was inquiring today morning itself when we were discussing about this topic.
I just showed that.
Yeah. Since there was a question and he wanted me to ask that.
See, one wants to show whether there is instability or not. So this
Yes.
is a I should stand against her. And These are two sandbags,
Sandbag.
each weighing about 3 to 4 kg.
Okay.
And the patient is asked to pick it up so that his arms are naturally pulled down with the gravity. So if there is a instability, the dislocation or the subluxation shows up, the clavicle stands out, something like this, which is best shown here. The downward traction and take a view. The film is about 15 degrees Kefalad projection.
Kefalad projection. Okay.
It could be done. It's
Okay.
10 degrees, not 10
10,
degrees
10
Kefalad,
degrees.
and it is called Zanka view. It is called Zanka view.
Zanka. Okay. Perfect. Alok, do we have questions on your chat box? Alok, you are muted. Please unmute yourself, Alok. Alok.
Yes, sir. I'll just confirm it, sir.
Yeah, just fine. Otherwise, then we go ahead with the next part of the talk.
There's nothing. So I'll just.
Yeah. Alok, sir, very rightly.
So there's a question. Hello?
Yeah.
Go.
Sir, instead of keeping the position of the patient, can we external rotate the limb and get the true AP view?
No. See, the idea is to have the joint line at right angles to the film. Externally rotating the limb, externally rotating the humerus serves no purpose whatsoever. We have to externally rotate the patient or internally rotate the patient in such a way so the shoulder joint line between humerus and the glenoid comes at right angles to this. So shoulder, we have to do only this thing. What I say is, we can't do that.
Yeah. So rather than rotation of the limb, it is rotation of the whole body of patient.
Whole body of
That
the
is
patient.
important.
That will
Yes, sir.
only work.
Alok, are you taking shoulder in this view only?
Sir, not always. Honestly, not always.
So we need
My
to go to.
technicians are trained that any shoulder, it has to be true AP and bilateral, standard. We also get patients from outside. So even the GPs don't ask, they just ask shoulder X-ray. We still do these two and report it. The radiologist also reports as true AP and bilateral. So that sets up a good trend everywhere that they understand what is happening.
Right. Dr.
It's
Kiran
full
Saoji,
teaching.
Dr. Kiran Saoji, sir, if you have any question, you can post it. I think he is not responding. Fine.
Yeah.
Sir, do we go ahead with the further
Yes,
lecture?
sir. Yes, sir. We go ahead.
Okay, before going to the next portion, I want to pay tribute to one of my teachers, Dr. Ellen Vora, who passed away this day before yesterday. Dr. Ellen Vora was associated with Bombay Orthopaedic Society from the first day till the Golden Jubilee, 50 years, and even later, it's now almost 55 years. He did not miss a single annual general body meeting. And he was secretary of the society for 6 years in the beginning, and the etiquettes and the discipline that he instilled then are still helping the society. He was my teacher also. He signed my thesis for final MS. Before I passed out, he was a tough master. On every round, he took everybody on a big parade, and it was a big firing session. But the day I passed, his attitude changed completely, and thereafter, he treated me just like a friend, and a very good and very benevolent friend. My association with him is of 53 years. I'm going to very sorely miss him in the rest of my days. Dr. Ellen Vora. Mrs. Bindu Vora was also equally involved with the Bombay Orthopaedic Society. And with him, she took a lot of society work on her shoulders. She also passed away 2 years ago. And after that event, Dr. Vora went downhill steadily till this Sunday. Then he passed away very peacefully. I mean, I'm sure everybody is going to pay tribute to him now and again, but this is my bit. let's get on with our thing. Radiographic positioning. Elbow joint is another one that's tricky. What is famous about elbow is that among the joints of the body, the elbow may be considered as a spoiled child. Its construction is delicate. It is very easily upset and resents harsh treatment. Was quoted by J.C. Jupiter, who attributed to somebody else. In our practice, we see it takes a long time for to get good function back to elbow joint. If you fiddle too much, then it really is difficult to get anything. If you let it develop by itself, the range of movement with the patient's effort, it always works in my hand at least. So how to start? I mean, the best treatment is to take the correct X-rays on the smallest injury, and for that we should know how to do that. When you want to do elbow X-ray, make sure that the shoulder, elbow, and the wrist are in one plane. This patient is sitting on a low stool so that his shoulder is at the level of the table, and then everything falls in line. Common mistake is to let the patient stand and keep the elbow down. Then you can never get a lateral picture, you will get an oblique picture. So use a low table, a low stool for him to sit down. Make sure that his arm is at the level of the table and the arm is something like this. You can see from here. Then you get a perfect lateral picture. When you want to know more about radial head, you take a grain field picture, grain field view, which is really, again, the shoulder and elbow are level, but the tube is tilted to 45 degrees at an angle on a pronated hand. With that, the entire head of the radius is off the ulna. In the exact lateral, you will see it is overriding. The shadow is overcast. But in this one, there is nothing. It's very clearly seen. The smallest fracture you can find out with the Greenfield view very easily. Patients find it difficult to extend, then we can even pass a film between the body and the elbow and take a perfect lateral. Uh, Either this way or this way, both ways, both things can be done. This fracture, this fracture. Or make sure that the point of the elbow is at right angles. Technicians are sometimes poorly trained or they don't understand the importance in the first place. But we have to insist or impress on them that this is the only way. I find if I insist more than 2 or 3 times, then the technician will exert himself to get the right one. If I say, okay, take lateral X-ray, he will, do whatever he wants. But many times now it is all digital, so I look at it and then tell him many times to repeat it. But when I repeat it, I tell them what was the mistake, and is there. Of course, he has a copy of my book also to look into it. But training the technician is duty of the orthopedic surgeon if he wants good X-rays. Elbow is difficult to extend after injury, so you can't get AP picture in one shot. You have to do two pictures. In the first picture, you allow the forearm to rest on the film and then take a picture. And the next way, you allow the arm to be in the same level and then the arm is now resting and you take picture. So in one shot, you get complete picture of the radius ulna complex, and this one you will get complete picture of the humerus. Then you can reconstitute the injuries for yourself. Otherwise, if you allow just one shot, you will miss something or other. When again, if you want to take picture of the hand, the same thing follows. Humerus, the shoulder, elbow, hand, they should be on one level in flat of the castle. And then the hand. Hand is always taken posterior inferior, dorso anterior. What AP and lateral. See, the nomenclature is where the ray strikes first is called first. So this is the dorsal side, this is the posterior side. So this X-ray would be called posterior anterior, PA view. In the hand, we always ask for PA view. If you took a lateral view, then there is an issue with rotation and the ulna and radius will not be on the same level. There will be rotation. So always we ask for PA view. Even if you ask for AP view, the technician will take you a PA view also. When it comes to finger lateral, it has to be perfect lateral, and it's difficult for patients to maintain it. So one can make a small stand of foam rubber, or any foam. Small pieces are stuck on each other, and the patient can rest his fingers in the appropriate position, and then we can get lateral pictures in perfect. In finger injuries, it is imperative that you take a lateral, perfect lateral. Any oblique picture, one is likely to miss the volar fractures very, very easily. So this stand is very handy. It can be made very easily in any clinic and should be very useful. For thumb, you require three pictures. This way you can take the AP. The fingers are extended away. If they are overlapped, we cannot see that the arm is fully pronated, and then you can take picture like this. This is for the lateral position. Again, take care of the fingers and the knuckles, so they should be out. One could get a lateral picture. And when you just keep him like this, you get an oblique picture. Thumb being so mobile, you need all the three pictures. So with thumb, your order should be epilateral and oblique. And the way to do, we just saw, you have to give special position. Then only you get the perfect pictures. Positioning for postoperative images is most important. And our postoperative time starts in OT.
ते आता राहू दे त्याला मला ऐकू दे चाल ना आता बाबा कर ना यार
A picture, an X-ray in OT is worth more than 10 outside. Image intensifier orthopedic surgeon is two sides of a coin. You must know your image intensifier. You must handle it very, very well. How to position and how to limb and the tube and then the interpretable. This is what with image intensifier, the orthopedician must know how to position the limb and the tube and interpret the view. After ankle reconstruction, we always want to know whether we have penetrated the joint or not. And anterior posterior, we have to use in the ankle mortise and anterior posterior. Mortise for clinical reasons is very, very popular and is very useful. So our tendency is to take mortise view first. Does that help? For mortise view, we have to bring the intermallear line parallel to the plate. For that, we have to internally rotate the ankle or externally rotate the tube. Here, the ankle is in neutral position, so we have rotated the tube externally. While on the other side, here, we have internally rotated the foot and the tube will remain and neutral. In both the instances, we have made the intermallear line parallel to the X-ray film. That is the mortise view, and what you can see is the Shenton line going across nicely. The articular gutter can be seen equally on all the three sides. This is equally seen on all the three sides. This is Morton's view, and this is so-called Shenton line. And there are various measurements that can be done, and that tells us that the joint is in good position. We can also find a space there where a round object can be put in. Secondly, this is very important. This Wagstaff tubercle and the ulna that should articulate at the plafond, and this is the right way. When we reconstruct, always look for this position, and the length of the fibula is just by this rounded space that we call it as Naya Paisa sign. That means a round coin. This coin now does not exist anymore, but it used to be something like this. It was introduced in 1957. That's the year I passed my matriculation. And the coin was to be issued on 1st of April. My exam got over on 28th of March. Post office was very close to my house. So I remember going to the post office to collect some Naya Paisa in change and then display it to my friends. So over the time, the value of paisa has gone so down that they have extinguished that coin no more. It's only a presenter's item. When you reconstruct, make sure there is a circular line that you can so- that you can fit there, and that if something is obstructing, then your reconstruction is inadequate. The fibular length is not recreated. Inadequate. Here there is no place for that naya paisa. So this needs to be redone. It's incorrect. There's a wide medial gutter here, and syndesmos is also open. Fibular length is inadequate. Mortise view in reconstructed joint has got joint line visualized in toto, equal in three sides. Fibular length is assessment, helpful in assessing syndesmotic correction. So it's a very useful view to know, Mortise view of the ankle. However, when it comes to implant, the Mortise view does not work. It only shows the standard view. This is the standard view. Foot in neutral, the film is in 90 degrees, and there we are. There is some overlap on the lateral side in the AP view. The medial gutter is well seen. Superior gutter is also seen, but the lateral gutter is over, is not seen properly. Ankle seen in 20 degrees external rotation. Overlap on the lateral side. Fibula is longer and unequal medial and lateral gutter. That is the AP view. So when we take X-rays, what happens? This is the post-op phase on the operation table, as you can see. If you take a AP view, then the the only medial gutter is seen. The X-ray beam can pass through and through, so it doesn't cause any kind of shadow on the joint line. In the Mortise view, what we have is first an obstruction by the anterior by the tibial shadow, then the posterior end of the fibula also casts a shadow. So this shadow can be easily seen on this side. Here we are. It is a summation of two shadows from the tibia and the posterior part of it is covering the joint line in the Mortise view. So any implant, even if it is inside the medulla, inside the bone, it may cast a shadow on the joint line and leaving you in doubt whether the implant is intra-articular in Mortise view. But if you change the view, it will show that exact thing that you want to see. There we are. So you'll always feel that the implant is inside the joint in Mortise view. This is the Mortise view. One feels the implant is inside the joint. We turn the ankle to AP view and it's well clear. There is no intrusion of the joint line. Why this is AP view? Because the lateral gutter is not properly seen. Only medial and the top gutter is seen. Clear overlap at this. So classic and Mortise view for reconstructed ankle use classic AP view. You will be there are many situations that I have described in this book, and it's a very useful resource for practical orthopedic surgery. As I said, it is only the shadows that we need to control. I mean, just to hands and fingers, one can create so many images. It's only interpretation. So positioning is the key. That is the ultimate. When it comes to plating and intra-articular views, we are always concerned whether we have penetrated the joint or penetrated the dorsal line. So we can position the limb and the film and get what we want. As we know, X-ray pursues a straight line. So if the implant is jutting into the joint surface, a line will miss it because it will have the bone will cast shadow and you'll feel it is inside when it is actually jutting. However, if we change the direction of the line, we will be able to see that. So changing the angle of incidence of the X-ray will give us a better and clearer picture. And we must know how much to tilt. Positioning is the key. Now, in this just AP and lateral picture, there's nothing much to talk about. So, posterior interview is standard. But if you take it just flat on the X-ray film, you will get some different picture. But if you lift it at tangential 14 degrees elevation, then you will get a clear joint line. So when you want to ascertain whether the implant has gone inside, even AP view, you should lift the arm up by 14 degrees. This is flat PA view, keeping the patients on the table. And now we have lifted it tangentially 14 degrees, and there is no need to worry. The implant is not in the joint. This is a false picture because of the projection. It's control of shadows. So 14, even PA view, you take it in 14 degrees, you will be a happy man. Tangential at 14 degrees gives you all the required. Laterally, this is neutral position, and 10 degrees from the this thing. There we are. You can see the joint line clearly at 10 degrees. There we are. Ulnar facet or distal best seen between 12 and 15 degrees. The radius has a curved articular surface, and the curvature is both the planes. So we want to see entire part whether the screw has penetrated or not. So to see the ulnar facet, you have to lift it to 12 to 15 degrees. We'll show that very clearly. Here we are. While using this plate in this situation, it is recommended that you should put the ulnar screw first. Reason being that you can then visualize that it is not penetrated. If you put the radial screw first, then this shadow will prevent you from seeing what's happening there, and you may make a mistake. But if you put the ulnar screw first, then the next, then just simply by increasing the angle of elevation of the wrist from the horizon, you will be able to find out position of each and every screw, whether it is intra-articular or outside. Ulnar screw first, always. Low angle till 12 to 15 degrees on the lateral view. There we are. Radial facet, distal seen at 20 to 25. We increase the inclination by 10 degrees or so. So we can see the other one. In practice, we move, our intensifier, we slowly change the angle and visualize the entire radial surface in the lateral view to make sure that nothing has been going inside. 20 degrees radial view, clear joint, and the wires are inside only. There we are. This way we can be sure that the joint line is not encroached upon, everything is under. And in the lateral view also at 20 degrees, you can rotate, move the wrist from extension to neutral to flexion so that your range of movement is also seen in the lateral view best, but at an angle, not at neutral, but about 15 to 20 degrees, you can see this. This picture would give you a satisfaction that you are not encroaching upon the joint line. Now, whether it is going through the dorsal cortex, sometimes you are lucky you can find it out, but there are three special views for detecting the dorsal screw penetration. Dorso-radial, that is the supination view at 20 to 30 degrees of inclination. That is the first position, and that will tell you whether you have penetrated the second extensor compartment. Supination view, dorso-radial view, second extensor compartment. 20 to 30 degrees in supination. Next one is a dorsal tangential view. It will show you the third compartment. The arm is resting on the table and the wrist is bent like this. For this view, you need to have a good image intensifier. The cheaper ones may or may not show, one has to struggle. But more expensive ones which are more refined and more powerful tube, they will show you. Of course, with practice, you still got to know what to do what, but they will show you that. The cheaper image intensifiers, I consistently find it difficult to find. The more expensive ones, yes, you can see. So this is for the third extensor compartment. This is the Leicester tubercle. This is third compartment. It is on the lateral side. Now do a pronation at 10 to 20 degrees and you will get the fourth extensor compartment. So we have from second, third, fourth, entire range we have seen, and just by tilting the by pronating and supinating the wrist at different angles and different inclination, you will find all the screws, whether they are, what is their position, and you will be satisfied. Better to know the location of the implant when you are in OT and patient is under anesthesia. Image intensive was wonderful, and depending on the quality they give us well. But I always insist on seeing a film, printed film, before I leave the theater. Many a times I had to go back and do a little adjustment, and that is much more satisfying and useful than finding it out afterwards in the X-ray department, and then one has to talk to the family and take back to theater, do some adjustment. That leaves a very unpleasant thing. So always see the X-rays in theater before you wash out. It is all about how to position the limb and the tube and how to interpret the view. All right. So this is the second half, and we can go from there. There are
Yeah,
questions.
Alok, do we have any questions? Alok, you can listen to us? Yeah, Alok, unmute yourself. Alok, unmute yourself. Yeah.
Hello?
Yeah. Go ahead, Alok, if you have questions.
Sir, there are no questions as such, sir.
Okay, fine. So two interesting things sir had in this session. So we were commonly doing for a lateral view of radius after fixation, the lift up view, the 15 degrees or 10 to 12 degrees lift up view. But sir has told in a PA view also it is useful. So I'll be using that again quite commonly now.
Very important for elbow, sir. What he told about inflection deformity, a lot of patients come with stiff elbow.
Yes.
So the elbow doesn't extend completely. In that,
Yes.
two different views, I mean, it was new, sir. Not
Yeah, that was good. Alok, may I request you just can reduce volume of your
Oh, so
laptop?
sorry.
Just a small thing. It is otherwise fine, no problem. Yeah.
I thought I was not audible.
No, you're audible at full peak, no problem. Yeah.
I would say that the three views for the wrist, pronation and dorsal flexion and the dorsal angulation and this, they are very useful because those screws we tend to go through very easily, and then there is attrition of the extensor tendon, etc., etc.
Right.
Before these three views were described, it was difficult to make out, and one had to make a rough judgment. But with these three views, one can really be sure that you are not penetrating the dorsal.
Yes. And after we have started using these three views, the need for getting a post-op CT also has reduced.
Yeah, that's
so that's very useful.
That's another thing.
Yeah. Right.
Shall I go to the next section?
Yes, sir. We can proceed for the next question.
A small section, but useful. Sometimes patients come with a small pain in the chest wall, and one can feel the tender spot. But X-ray many times does not show the fracture or any injury. It's difficult to explain what's happening, etc., etc. However, I found that such isolated rib injury can be easily diagnosed or seen on a sonography stuff. This lady, I remember she just came and with her husband she came, but she was very reluctant to give me any history how it happened. So I didn't go into any details of their bedroom ongoing. But when I spotted a very tender spot, I requested for I could have done a CT or MRI, but since sonologist is available in my clinic, I just requested him to use his skills, and we were able to find it out very easily. This is the normal rib, and that he can do that. And this is the broken rib. You can clearly see these two broken edges like that. This is sorry. Here we are. Absolute normal, no breakage. But when we go here, we can see two pieces. And the beauty is that the sonologist can put the probe at that spot and press a little harder, and the patient immediately tells you, oh, this is the spot, don't press. So that's a double confirmation. You can visually see it and know that it's a break, but you press it a little harder and the patient says, oh, doc, stop it. And you can also see the hematoma around there as an additional. This thing, all this dark area, this signifies fluid. So it is a hematoma, fracture and hematoma. Advantage is that it is a bedside, quick and personal. Now with this PCP and DT, it is not possible to go bedside and do it. But certainly in the clinics, it can be very easily done. This quick, personal, and much cheaper than CT or MRI. So if we know what to see, then we can immediately spot it out, and it is very easy. I find this very useful, and I've been using it very regularly. One suspect 3, 4 fractures, then one of course needs an X-ray and CT. But isolated fractures, they always work out with this one very well. So there is one more section, and that will call. That is a little. The next half is a little futuristic stuff, but it is worth considering that. See, at the moment we have only X-rays at our disposal as orthopedic surgeons. Very few would have associated. Um, Very few would have associated CTs and MRIs there. Big hospitals is easy, but in smaller clinics, it is not all that easy. But this is a machine which takes digital tomograms, digital osteosynthesis. It is not a regular CT or MRI machine. It's much smaller, and the radiation involved is also much less. The technique is well established in breast sonography. Um, in breast, the tomosynthesis is very, very common. These days, almost every center has this thing. They do a sonography and then do this digital tomosynthesis. But now it is available for musculoskeletal things as well. It has got a high resolution. Most important is low radiation than any CT scan. CT scan gives you a lot of radiation that we don't realize. But this low radiation and tomosynthesis, what it does is removes the overlying structures and enhances local tissue separation and depth information. This imaging can be used for vasculars, dental, orthopedic and musculoskeletal, mammography and chest. All these areas are using it. Mammography is well established, but in orthopedics also now it has come in a big way. Difference is that CT requires a set of 180 degrees data. You have to go right round and then only you can say at least one set. If not, in this one, it is limited. It doesn't have to go round, right round. Only a limited one and low number of exposures. Only 7 or 51, depending on the part. but much less than CT scan and much less radiation than CT scan. It works on this principle that was established in 1917. This is a thing which is complex for all orthopedic surgeons. What it really says is that if we know the measurement of two sides of a triangle, then by formula you can work out the third side. This is easy to find out. If the rays are going like this side and this side of the triangle is known, you can always predict the length of the other side, which is simple mathematics. So with that, and of course with the help of the computer and complex calculation, now with the limited exposure they can do just by going from here to here with the X-ray tube, they can predict the entire size by calculation and reformatting with the help of the uh, computation. Fewer projections to perform the reconstruction, low radiation and low cost. This is a simple machine like this, and this table goes right round. Ah, there we are. There's a video there. I didn't realize. There we are. This is they're doing a cervical spine data acquisition. The machine is just going right around that area. The wrist. Two passes and it gets all the that you need. Lumbar spine. So appears to be quite straightforward, and the protocols are available for all this, which is like almost everything in the body that we need on day-to-day basis that is available for digital tomosynthesis. The medial clavicle, one on plain X-ray, one doesn't see anything, but patient has a lot of pain. One can go for a CT scan or can go for a digital tomosynthesis. And if you see the fracture, can be visualized by that thing very easily. One or two passes, and there we are. You didn't see the fracture. Here is the fracture. That much, which was not seen on the normal chest X-ray, but when this synthesis you can find it. For such a thing to go for a CT scan, of course you can, but this is much more advantageous to the patient. It's economical and also less hazardous too because the radiation dose is very low. So rest a small fracture on the AP view, PA view, sorry. They are doing star. So you can see that step very well and then take a suitable action of fixing it with a lateral plate. Plain X-ray wouldn't show much, would it? Plain radiograph of scaphoid. Um, the suspected fracture here, but if you do tomosynthesis, you will see that the fracture is clearly seen there. Early detection of cartilage erosion is important in treatment of rheumatoid arthritis, and with these tomograms, it can be done. With hardware in the bone, it is difficult to make out that the non-union is happening or not happening. What is the status? You do a tomograph and always find out a very clear line that there is a delayed union or non-union. There is no question about failure of union in this side. Can easily see that the joint is well contained. It's not going out of whack just with the help of this tubercle. Well contained screw in the PB crane. So tomosynthesis is the future. It's limited in depth as compared to CT, but it's very useful for musculoskeletal things. It can be housed in smaller clinics. It's cheaper and would be very useful. So that is the end of today's session.
Yeah. It was interesting to learn about tomosynthesis. So is this same as yesterday's tomograms we used to do in X-ray departments?
The principle is same. They take one or two this thing, but the radiation is much less, and all the data is picked up digitally, and then it is manipulated to reconstruct. In earlier days, we used to have those tomograms. Only one you could fix it to 2 centimeter, 3 centimeter, 4 centimeter, something like this, and you could get only one plane. What this can do is take it at various levels and then calculate it and reconstruct the whole thing as a object there. So there's a big role of the computer to reconstruct and reform the image,
Okay.
and also less radiation to the patient. Both the things. Hi, we can see Kiran now. Hi, how are you?
Yeah. Now we can see him. He has reached. Yeah. So another question is, you told about sonography for fracture rib.
Yeah.
Is it more better for detecting costal cartilage injuries, the anterior part of?
Yeah, you can. I mean, costal cartilage, you'll have to go for MRI, but with localized sonography, one
Yeah.
can. I never used it for costochondritis, but I have done it over fracture. But by reasoning, it can be visualized also.
Also, okay.
What to make out of it is up to us. I
Right.
usually go in the sonography room and stand with the sonologist, and we two together work out, because I know a lot about the patient and he knows a lot about the machine. So we put together our minds and then come to some conclusion.
Okay. Absolutely fine. So in this series, you have not included the scaphoid, which also some delegate wanted to know.
Scaphoid, yeah.
Yeah.
This
You can.
tomosynthesis,
Yeah.
tomosynthesis can show you that.
Okay.
This scaphoid, there are 8 views for scaphoid in different angles, but they all, they have limitation. X-ray has limitations these days, and right from the beginning, it has improved. But this thing with digital, it is even better. But still, there is a limitation because of the penetration power of the X-ray. When we do a CT, we take help of the computer, and in CT there is much more radiation than simple X-ray. One CT of the wrist is about 5 or 6 X-rays of the wrist, because it is taking data all around, and the computer then reconstructs it. So that is far more superior than this thing. So these days, if one is in doubt about X-ray, simple CT scan is the answer. Unless you have tomosynthesis, then you can go for tomosynthesis.
Okay.
Otherwise, no halfway through there.
Okay. Alok, do we have any question on your chat box? Yes, please go ahead. You unmute yourself, Ashok. Alok.
Muted.
Yeah, fine. Perfect. Yeah.
Sir, 2 questions for sir.
Go ahead.
Sir, the radiations of digital tomosynthesis, is it lesser than X-ray also?
Say it again.
The radiation levels of digital tomosynthesis,
Ah.
are they less than the X-ray?
Much less than CT. Much less than CT.
CT, much less than
But
CT.
they cannot be less than X-ray.
X-ray,
They
got
would be a little more than that. But one CT is definitely 7 to 8 X-rays.
Yes,
This
sir.
is probably halfway through.
Okay.
It still has to go 15 to 60 degrees around. So it is going to give some radiation. Exact data I don't have, but the thinking of common sense tells me that it is less than CT.
So is it available or it is?
In the
Sorry?
pipeline. Is it available readily or is it in pipeline?
No, it is in pipeline.
It is in
As I
pipeline.
said, the technology is available. The breast centers, they regularly do this tomosynthesis. I spoke to some radiologists about this, but they were not very receptive. So we have CT and MRI, why do you need this? So I thought there was some professional rivalry there. If they are less expensive and they do not occupy much space, then more or less the orthopedic surgeons will only buy it and use it, I think.
Yeah.
So there are a few questions, sir.
Yes.
Yeah, go ahead.
Well, go ahead.
Dr. Jyoti is asking what are the radiological signs of posterior dislocation of shoulder?
I'm going to take out this because there's some issue. Now, can you repeat the X-ray?
Yeah,
Yes, sir.
Repeat the question.
Alok, reduce your voice. It is good. Very good.
I have the issue.
So what are the radiological signs of posterior dislocation of shoulder?
Radiological signs of posterior dislocation of shoulder.
Yes, sir.
In true AP, you will see a radiology. In true, if you take a true AP, you will find the overlap in the two articular surfaces. That is one. You take a bilateral, you will also find it posteriorly dislocated. Thirdly, you have to take a CT scan, then you clearly see that it is lying behind the this thing. More often than not, you will find it is hinged between the it is hooking onto the posterior border of the glenoid. So these are three signs.
Sir, another question.
Yeah, go ahead, Alok.
Dr. Rameshwar Datta, how to get good lateral view while operating proximal humerus? Position of the X-ray tube and the intensifier.
Yeah, I find it. Say, I usually keep the table flat and patient lying prone, and then bring the X-ray tube from the head and side. The AP is quite fine. Once I got the AP view, I then rotate the limb and get the lateral view, almost lateral, not complete perfect lateral. You can also rotate the tube and get a better view. See, all that matters is you should have two pictures at 90 degrees. It doesn't have to be perfect AP, perfect lateral. They can be also 45 and 45. That is also still 90 degrees. So any two angle views, preferably at 90 degrees or less, they are good enough for us. It's a bit trickery, but it is manageable.
Alok, it seems you have one more question.
So there are a few more questions.
Yeah, go ahead.
Dr. Milind Joshi is asking, if I ask for a hand AP view instead of a PA view, how does it make a difference?
Oh, I wish I had put that picture here. In PA view, you will find the ulnar styloid and the ulnar notch of the radius being incongruent. While in AP view, the ulnar styloid will be slightly rotated. The styloid will be side by side in PA view, but in AP view, it will be slightly rotated. It's easy to make it out. Once you see the X-ray, you can always find it out. You have to look at the position of the ulnar styloid process, and that spike will be in a different position on rotation.
Right. You have more question, Alok?
Yes, sir. Yes, sir.
Yeah. Go ahead. That is answered.
So is it a better option that digital tomosynthesis is better than scanogram to calculate the mechanical axis deviation?
Scanogram is just an X-ray on a larger scale. Ideally, it should be taken on a film which is about 40 inches long. But somehow it becomes very expensive, and because of reasons of economy, most centers will not have it. They will do it on a computer and then add it up. That's they call it stitching the two X-rays. So that is an X-ray. That is not a tomogram. What I showed tomosynthesis is a tomogram which will give you more details layer by layer. So there are two different things, oranges and apples. There's no comparison. Scanogram has its own place. Tomosynthesis is a different place.
Dr. Joshi is interested in knowing the cost of digital tomosynthesis.
Cost of?
Digital tomosynthesis.
I have no idea.
Since it is pipeline, so we will not have.
Yes, sir.
Ask GE or Siemens, they will probably go to their head office and find out. They
Yeah.
won't.
And there was a suggestion, sir.
Huh?
Please continue this series of Tuesdays with Dr. Thakur, sir.
So that's very nice, and we all of us do feel that yes, we do get a lot of good inputs and valuable learning points, and therefore we are there on Tuesdays with Thakur sir. So this is a request to Thakur sir. So whatever topic you want to take, I think whenever time permits, whenever you are comfortable.
Let's see, the lockdown is getting over, so I think this is must get back to work and do something.
Yes.
And get more experience than talk to you.
Right.
We had long conversations, a lot of fun.
My own difficulty I'm asking in getting in our analog machine X-ray, we do not have a digital yet. We have not taken it because I basically enjoy analog X-rays. So getting a digit X-ray, it becomes more often blackish than or overexposed, even if you reduce the factors. So any tips?
Digital X-ray is again very scientific, and one has to make the adjustments. Many places fail to make good adjustments. In fact, was a radiologist in my neighborhood, and somehow his X-rays used to be so shabby. Digital X-rays used to be so shabby. Before I started seeing him with X-ray, I always thought it is difficult to spoil digital X-ray. After that, I knew everything could be spoiled. So it is the adjustment, and it depends on the radiologist. And the company people will also do that. And Dr. Chandak, if you have not bought digital X-ray, order it tomorrow morning.
Okay. Thank you. Thank you, sir.
One more thing, have the additional monitor on your consulting table. I have that facility. The radiology room is about 60 feet from my place. But it is now wireless. It comes by Wi-Fi. And every patient's X-ray I see while consulting. Patient sits here and I sit here along. And he keeps on looking into my projector. So I have got a special screen here. So patient sees on this, I see on this, and then that consultation has a different meaning altogether. And I'm surprised that you don't have it. So by end of June, you should have one. And
Thank you so much.
But
Thank you so
make
much.
sure you have a monitor on your table. That is real fun.
Okay, perfect.
Sir, there is a suggestion from Dr. Sauji, sir.
It is cheaper than that washing machine you showed for the injuries.
Yeah.
Injury washing machine you showed.
Right.
It is much cheaper. I think it's now less than 3.
Yeah.
It's only adjustment.
Sauji sir suggestion.
Sorry?
Okay. Dr. Sauji sir wanted to ask some question. No?
Yeah, sure.
He has a suggestion, sir.
You can put up.
Sir, he has a suggestion that each and every orthopedic surgeon should have a cassette stand.
Cassette stand, no?
Yes, sir.
Any comment you want to make, sir? Cassette stand. So something like a chest stand, you mean to say?
That is a cassette holder. That big one, yes.
Cassette.
I mean, we will need X-ray chest anyway, and that is the easiest way to take it out. It's not expensive stuff. It occupies a little space, but it's good. You should have that. Everybody should have it. Actually, in digital X-ray now they have come up with a cassette only, and that cassette you take X-ray with your standard equipment, 15 mA, and as soon as you shoot that, all the data is emailed to your computer. You don't need an additional machine. All you need is that extra cassette, digitalized cassette, and the entire data is sent to your laptop. You can do that and finish it off. So for single standalone orthopedic surgeons in Maharashtra or everywhere else, that is a big asset.
DR system.
That this system, only one single cassette. I have seen this. Somebody showed me to me.
Yeah, DR system, the digital radiography.
Digital radiography, digital cassette. Only you have to purchase only the cassette and the software, and on your laptop or your desktop, everything comes within seconds. As you finish shooting, it everything is there. So it's very useful.
Perfect. So thank you very much, sir. It was really wonderful discussing small points and learning small points. And
thank you, sir. Thank you so much.
Yeah, that was very good.
Thank you. I had fun also hearing and talking here.
Yes, it was. Everyone enjoyed. Ashok, Ashok, are you there, Ashok?
Ashok is not there.
Ashok is not there. He is streaming other programs also simultaneously. Yeah. So, yeah. So let's see if he is joining within a second. We will thank him and then. Ashok, are you there?
Maybe call him on the phone.
Yeah. So that we tell him that we are finishing. I'll just come. Yeah, I think he's talking to someone. And Alok, it's a time to sum up from your side and thank all the delegates also.
Yeah. Sir had almost told us about all the different views for orthopedic surgeons, starting from shoulder true AP, that was very important. That was a modified Grashe projection, and also told about Y-lateral view. Then he told us about how to diagnose the AC subluxation with having heavy sandbags in your both the limbs, so that you can accurately diagnose them. And then he told how he compared elbow to a spoiled brat. That was fantastic, sir. The Mortise view for ankle, the Naya Paisa sign, that was fantastic, sir. That was a new point. Naya Paisa sign. Then the Wagstaff tubercle, that was, most of the people might not have heard about it. Then the Mortise view, the syndesmotic injuries, the positioning was the key. You always emphasize on the positioning of the patient. And then for the wrist, you told us about different views in different compartments. That was really quite a good learning for all of us. The dorsal cortex penetration, you should avoid that. How should you take the X-ray in dorsal view? Then pronating the wrist for the fourth compartment. And finally, you told about the USG for fracture ribs and the digital tomosynthesis. So overall, we had all a good learning from you, sir. Thank you so much.
So we definitely pick a lot of points. And I was taking extra acromioclavicular joint with sandbag in one hand. So now I would modify in both the hands. Yes. So it's very nice to learn all that, sir. So thank you very much for bringing up this series again. And thank you, Alok, for moderating so well. I think Ashok has
just come back.
Yeah, just come back.
Yes, I'm always.
Yeah, you are always there. And that is what we wonder about, that you are providing a technological support absolutely without any glitches, and you are there timely to support us. So thank you very much, Ashok. We had a nice discussion and a good radiographic positioning. And there was a suggestion from one of the delegate that the series should be continued. So we'll request you and sir, whenever both of you find time and platform, we would continue whenever some topics are built up, maybe over a period of time and gap,
Yeah.
maybe after a month or so, whenever sir permits. And
Maybe
he's
we can
ready.
make it a once in a month series or once in a fortnight.
Yeah, as per sir's comfort and
Convenient.
teachings, yes, we can.
And make it at late evening, around 8 o'clock, 9 o'clock.
Yeah. So as sir says and as sir agrees, I
Yeah,
think we can go ahead with it. So
Okay. Fine. Thank you, everybody, for
thank you,
listening.
thank you, sir. Thank you so much. Huh? Thank you, Alok. Thank you, Ashok.
We'll see what
Thank
we
you,
can
sir.